So the diagnosis of schizophrenia comes with some very um, a wide variety of symptoms that are possible, right? And these symptoms can either be positive symptoms in nature, and that means things are present that shouldn't be there, things like hallucinations, excuse me, or they could be negative in nature. And the negative symptoms are things that should be there that aren't there, things like normal social interaction or caring about what happens to them or their loved ones. Those things can be missing in schizophrenia, right? So let's go through some of the actual things and identify whether there are positive or negative symptoms. So let's talk about thought disorders. These are some of the symptoms of schizophrenia, right? So in your thought disorders, we talk about delusions, right? Delusions are thoughts that someone has that seem very, very real to them, but actually aren't true when you look in the context of what reality is, right? So delusions can be come in a number of different forms. You can have organized delusions, which are more focused on something that is definitively one thing that a person could be delusional about. So, like, we had a patient that thought that when he got discharged, that his brother was going to come after him, right? And he was not delusional about a lot of things in his life, but the one thing he was delusional about was the fact that his brother was going to come and attack him when he got discharged, even though the brother was fine and wanted all the success and had never aggressed against him. So that is a more focused and organized delusion, right? Or you can have more generalized delusions where people are paranoid or worry about everybody in their environment being against them. So that's more of a generalized type of delusional system. Also, you can have two other types of categories of delusions, right? One is paranoid delusions. So, paranoid delusions, I just gave you an example of that. You fear everybody in your environment is out to get you, right? That can be a paranoia. Or you can be paranoid about one thing. Like, I had a patient who kept saying the Chinese mafia was out to get him, even though there was no proof that that was true. Um, Also, you can have delusions of grandiosity, right? So, grandiose delusions are things like, well, I'm God or I'm the King of England. And no matter how much you argue with someone or tell them, look, that can't be true, here's a picture of the real King of England. They still believe in their mind that they are that person, right? So these are grandiose delusions, and they can also involve something very specific. Like we have patients that have grandiose delusions that they have $2 million in the bank, right? Even though they are broke and don't have any money. So that's a grandiose delusion also. So it can be something very specific, or we have patients that have grandiosity about a wide range of things, right? They're grandiose in general. They think they're president of the United States. They think they have had babies with Oprah Winfrey, et cetera, et cetera. So there are many different categories, and these are more generalized delusions of grandeur, is what we call them. Okay, let's talk about. So that's thought disorders. That's part of our thought disorders. Let's talk about perceptual disorders. So under perceptual disorders, we have hallucinations, right? And these are positive symptoms because these are things that should not be present that are. A hallucination is a stimulation that anybody gets that seems very real to them, but is actually not something that's reality. Uh, Patients can experience any sense, can be prone to hallucination, right? So you can have a hallucination that you're smelling something, even though the smell isn't present. You can be hearing things, you can be seeing things, you could be feeling things crawling on your body. All of those types of senses are prone to different types of hallucinations, right? Out of when we look at hallucinations, about 70% of the patients that have hallucinations, they have auditory hallucinations. Those are by far the most common hallucinations. Most times when people talk about hallucinations, they can identify a voice that talks to them. And usually, if someone is having hallucinations, that they're hearing voices, they can tell you what the voice sounds like, or whether it's male or female, or whether they believe the things that they're saying. So these voices can be range from being, a person having insight and saying, "I'm not going to pay attention to them," as in A Beautiful Mind, the movie, or we can have people that do pay attention to the voices and feel like if they don't do something about what the voices are saying, that they're going to have a real problem, right? So those more severe reactors that have auditory hallucinations oftentimes suffer from something we call command hallucinations. Command hallucinations are voices that say, you must go do this. And the problem is that the feeling that accompanies that, the anxiety that accompanies the hearing of the voices, cannot be addressed unless the person actually performs the act that's being suggested, right? So command hallucinations can be very dangerous because, as for instance, the son of Sam was an example of someone who was having auditory command hallucinations. He heard dogs talking to him, telling him to murder people, to shoot people, and felt as if he could not erase those voices in his head unless he actually carried out the act, and that's why he ended up killing a number of people in his killing spree. So he was hearing his instructions from the dog. And these are some of the more dangerous cases when a person suffers from command hallucinations, auditory hallucinations, where they hear a voice saying, do this, and they feel as if they are compelled to do this in order to accomplish some fictional thing. You hear if a mother that drowns their kids because they're hearing a voice saying, save them from the devil. This is again, a result of command hallucinations, which is what makes the command hallucinations so dangerous, right? So as I said, any of the senses can be prone to hallucinations, and this type of thought disorder is very common in schizophrenia. Well, now let's talk about motor disorders, right? So motor disorders can fall under both positive and negative symptoms, because with motor disorders you can have strange facial tics. So those things are like things that are there that shouldn't be there. And then you can also have catatonia, which is a state where you see a patient go stiff and not move at all. And if that happens with catatonia, they develop a state called waxy flexibility. That's a really sort of interesting thing that the mind does, which is if they are posed in a certain position, like let's say their arm is stuck up here, if they're under waxy flexibility because they're catatonic, right, you can move the arm into a different position, almost as if they're a mannequin, and it will stay where you move it to. So that's an example of waxy flexibility. Not a common side effect, but it is something that happens to schizophrenics with motor disorders. Facial tics are far more common, and sometimes you have an overactivity of different muscles, twitches, things like that can be a result of either schizophrenia or an overuse of a side effect of the medications that are given, right? Then there are the affective disorders. And again, affective disorders can be either positive or negative. You can have someone who laughs all the time because they're schizophrenic. That's a positive symptom because there's laughing where it shouldn't be present. Or you can have someone that has a flat affect, right? A flat affect is very common, where someone is asked a question and they just answer like with nothing. Yeah, I guess. I don't know. Maybe. So that's common also in schizophrenia, where they don't have the proper mood to match the situation. So, how do we treat schizophrenia? Well, again, you can have cases of schizophrenia that are more or less severe, but schizophrenia does tend to be a pretty debilitating disorder if people are responding to their symptoms in a manifest way. So, we know that treatment is usually going to have to involve some form of antipsychotic medication. I'll tell you about that in a second. First, I want to tell you about some of the causes. So, we know that there is a genetic predisposition to schizophrenia. That is to say, if it runs in your family, you're more likely to potentially be exposed to it. We think that schizophrenia is a genetic abnormality. There's actually a lot of testing being done right here at Cold Spring Harbor in Long Island on medications and causes of schizophrenia. And we know that when you're predisposed to it, that is to say it runs in your family, if you have things in your environment that bring it out, you're more likely to develop schizophrenia than the general population. These could be things like drug or alcohol ingestion. It could be stress. Any of these things can act as a trigger, a traumatic event. Any of these can potentially lead to the development of schizophrenia. The incident of the development in the general population is about 1 in 100, which doesn't sound like a lot, about 1 to 1.5% of the population. It doesn't sound like a lot, but really it's more common than we generally think. And it's a very, very debilitating disorder, right? So schizophrenia is treated in a number of different ways. As I mentioned, antipsychotic drugs. So a lot of these antipsychotic drugs started to be dispensed in the early 60s. What we call the old school medications, or actually in terminology we call these the typical medications, are things like Haldol and Thorazine. Now, these things are still used, these drugs are still used in order to combat some of the symptoms like the hallucinations and delusions in schizophrenia. The problem is that these medications led to the development of serious side effects when taken over a long period of time, right? So most commonly, after being prescribed antipsychotics for 20 to 25 years, people would develop something we call tardive dyskinesia. Tardive dyskinesia is similar to Parkinson's disease in that it involves involuntary movements. And so people with tics or movements of the fingers, a lot of times you'll see people that are homeless, and a lot of times this is the development of side effects from taking psychotropic medications for many years, right? We do have medications that help to combat the side effects, but unfortunately it is a progressive type of thing that happens, and oftentimes people can suffer serious neurological damage and impaired lifestyle because of the side effects. So the good news is there are new drugs that we use that are considered antipsychotics, and this category is the atypical type of medications. These include things like risperidone and Clozaril. Now, at the hospital, there is a push to put as many people on Clozaril as an antipsychotic as possible. Why? Simply because it tends to be effective, and also the fact that it produces less long-term side effects as far as we know. It doesn't produce as many long-term side effects that lead to the development of the tardive dyskinesia. So we do try to prescribe medications that will be far less resulting in things like these side effects, these potentially severe side effects. What other types of therapy are used in the hospital to address serious schizophrenics? So what we find is as the medication takes hold, a lot of times people do get a little better, and even though they're having symptoms, they may be far less, so they're able to function. So what do we need to do with them from a therapy standpoint? Well, many times people that have had severe schizophrenia have lost some of their social skills. They don't know how to interact in public, and it's very difficult for them to function. So part of what we do for therapy is we give them training in areas that help them, that will help them to go back into society. Things like shopping skills and ways to apply for a job and ways to help to support themselves and maybe cook a meal. All of these things would be a type of therapy they might undergo. So it's really a retraining of skills. Also, we develop things such as behavior plans that help address individualized behaviors to try to help patients with schizophrenia find alternate means of expressing themselves, things that aren't destructive either to themselves or to others. So they ideally learn better coping skills and learn about their medications and how they can safely take medications so that they stay on them for the long term. Most of the time when we find that people come back to the hospital after they've been discharged, it is really because of the fact that they stop taking their medications, they stop participating in activities that help to give them purpose, and so what we call decompensate, and decompensation can lead to a rehospitalization, right? So that is a good overview of different types of therapies that we utilize. And I wanted to just give you the final thing was developing of a behavior plan, right? So many of our interventions, we attempt to develop behavior plans for behaviors that are particularly difficult to come under control. So part of the therapy mode that we use in any type of therapy is psychotropic medications, the prescription of medications that can help us to get to a point where you're ready to engage in some sort of therapy. And then we like to use behavior plans in the hospital in order to, in a very organized manner, try to help shape behavior. Now, this goes back to our previous chapters on behavioral psychology and what type of interventions. So behavioral psychology is particularly used in the hospital in order to develop goals that are both measurable and treatable. So we like to train our staff using the reinforcement survey I mentioned way back, so that through the use of sometimes edible reinforcers, sometimes music, sometimes extra attention sessions, sometimes the use of particular types of equipment, such as drawing pads. All of these things are utilized for behavior plans. And basically the idea is, as a person setting behavior plan in the hospital, as the psychologist would do, you identify a behavior you're trying to reduce, you make a plan that involves a reinforcer, and then you train the staff that is working with you in order to provide that reinforcer. So it may be something like a token economy where you earn stars, and those stars can then be cashed in for different types of reinforcers, like food reinforcers. So a lot of times you'll see a behavior plan where someone will have to earn a star for that day or for a particular shift, like a day shift and an evening shift, in order to cash that star in to get an edible reinforcer. That would be a token economy. So these are very common interventions that we use when we talk about therapy. So I hope that you got a good broad overview of both psychiatric disorders and of course, the therapies that we use to address them. Thank you for all the time and attention you paid, and I hope that you carry it with you as you go. Take care.